Hi, everyone, and welcome to my lecture on anemia of chronic disease. This week in pharmacology, you are going to be discussing different hematological drugs. So this is not a PowerPoint presentation. This is purely more of a podcast. So feel free to listen in your car while you're driving or while you're cooking dinner. Just follow along and listen of anemia of chronic disease. So we're talking about what is anemia of chronic disease. It's mild to moderate normochromic, normocytic, microcytic anemias associated with chronic diseases. The red blood cell lifespan is shortened from the normal 120 days down to 60 to 90 days. All right, so normocytic is the average size of the RBC. Normochromia describes the amount of average hemoglobin found in the red blood cells. So etiology. Chronic systemic infections, inflammation, malignancy, causing production of pro-inflammatory mediators, which inhibit erythropoiesis and leads to imbalance of iron homeostasis. What's the incidence? Most common in elderly with chronic disease, seen in children with chronic illnesses, common with malignancies. It's present more than 50% of the time. And the second most common anemia behind iron deficiency anemia. What are our risk factors for anemia of chronic disease? Presence of chronic infectious inflammatory malignant disease. Think about HIV, bacterial endocarditis, tuberculosis, osteomyelitis, fungal parasitic infections, lymphomas, myelomas, carcinomas. We have chronic systemic diseases that lead to anemia. Rheumatoid arthritis, lupus, sarcoidosis, temporal arteritis, inflammatory bowel disease. We have hepatic disease or hepatic failure, chronic heart failure, coronary artery disease, chronic kidney disease. That is a big one. We have cytokine dysregulation, which is also a fancy term for anemia of aging. We have hypometabolic states, patients with protein malnutrition, thyroid disease, panhypopituitarism, diabetes mellitus, or Addison's disease. What are our assessment findings? They are dependent on the underlying disease. Patients can be asymptomatic. Patients can have dyspnea on exertion, fatigue, headache, anorexia, weight loss, lightheadedness after mild exercise, palpitations, or angina. What are our differential diagnoses for anemia of chronic disease? Iron deficiency anemia, thalassemia. We have sideroblastic anemias, drug-induced marrow suppression, hemolysis, endocrine disorders, or dilutional anemia. Think of your patients that get massive amounts of fluids during, a cesarean section, and they get an actual dilution anemia. What are our diagnostic studies for anemia of chronic disease? We're going to do CBC with a peripheral smear. Or we got normocytic, normochromic red blood cells. Because if they're not normocytic or normochromic, then there's something else going on, right? If they are microcytic or macrocytic, then we're looking at B12 or iron deficiency, not anemia of chronic disease. Hemoglobin ranges around 9.5 to 11. Serum iron levels can be decreased. Total iron binding capacity is decreased. Transferrin saturation is usually decreased. Serum ferritin is usually normal or increased. Our red cell distribution width, that RDW, usually remains normal 11.5 to 14.5%. Mean corpuscular volume, MCV, is either normal or slightly decreased. Our reticulocyte count is either normal or decreased. We can get an elevated ESR or an elevated C-reactin protein. Non-pharmacological management. Our treatment is going to be aimed at the control of the underlying disease process, and we need the patient to have energy conservation with frequent rest periods. What about pharmacological management? Administration of iron is usually not indicated for anemia of chronic disease. Transfusion of packed red blood cells is indicated if the patient's becoming symptomatic. consultation or referral as needed for management of the underlying disease. And what about our follow-up? As needed for evaluation and management of the underlying disease. Anemia of chronic disease is usually not progressive, though hemoglobin hematocrit should still be monitored every 3 months. So what's our expected course of treatment? That is also dependent on the underlying disease. Iron deficiency anemia can coexist with anemia of chronic disease. So a look at the ferritin level is going to help you differentiate between these two anemias. So what's our possible complications? Worsening of the underlying chronic condition. Okay, let's move on to another type of anemia. What about folic acid deficiency? What is that? Macrocytic anemia due to folic acid deficiency. Folic acid is a water-soluble B vitamin which helps to repair DNA, make DNA, and produce our red blood cells. Folate is found in animal products, leafy vegetables, liver, citrus juices, fortified cereals. Folic acid refers to the synthetic form. Folate is the word used to describe the vitamin that's found in nature. This becomes important if a patient has MTFHR variant because they cannot methylate their folate, in which case if you give them cheap folic acid, their body will not know what to do with it. Let's go over etiology. Now, this is your first week with me doing these podcasts. So basically for different entities that we're going to talk about during this course, you're always going to have a description and etiology, incidence rates, risk factors, differential diagnosis, diagnostic studies, so on and so on. So etiology, inadequate folic acid intake, especially in our elderly, in our chronically ill, in our alcoholics, in our infants that are not on cow's milk and they're on goat's milk. We have malabsorption syndromes. Think of your SPRUs, your short bowel syndromes, your celiac patients. Increased demand for folic acid, pregnancy, malignancy, severe psoriasis, rapid growth, megaloblastic anemias. Decreased folic acid utilization when a patient is on certain medications, methotrexate, Bactrim, different seizure drugs like phentoin. Incidence rates of folic acid anemia, most common ages 60 to 70, women of childbearing age, the peak incidence, children 4 to 7 months of age, and non-Hispanic Black women. Risk factors pretty much go back to that etiology: low birth weight infants, poor diet, eating overcooked foods, protein energy malnutrition, kwashiorkor disease, for example, or pregnancy. What are our assessment findings? This is an insidious onset. Similar clinical and hematological features as the vitamin B12 deficiency anemia, but no neurological symptoms for the most part. We can get atrophic glossitis, which is a red, itchy tongue, usually red, shiny looking tongue. Angular stomatitis, those little cuts, in the corners of the mouth. We get a sore mouth and tongue. We can get GI symptoms, nausea, vomiting, abdominal pain, diarrhea, weak, fatigue, lightheaded, pallor, poor concentration, irritable, shortness of breath, palpitations, tachycardia, postural hypotension, darkening of the skin and mucous membranes. If it's an infant, they might have failure to thrive. They might have chronic diarrhea. What's a differential diagnosis for folic acid deficiency? That would be pernicious anemia. Let's think about our diagnostic studies, putting on your little NP hats. Let's think about, what do you think ahead of time? What are you already hearing, all the different things that we have just discussed? What are some of these diagnostic studies you're going to think about? Serum folic acid level. It's going to probably be decreased to less than 3. Homocysteine levels. They'll probably be elevated because folate's needed to convert homocysteine to usable amino acids. Methylmalonic acid. It's going to be elevated in B12 deficiency. Mean corpuscle volume, that MCV, probably greater than 100. Hematocrit's decreased. Hemoglobin's usually normal. Red cell distribution width, RDW, is usually elevated. Reticulocyte count decreased. The RBC folate level is usually less than 150. Your serum ferritin levels should be normal. Your total iron binding capacity should be normal. Your lactic acid dehydrogenase, that LDH, is elevated. Vitamin B12 levels, normal. And as usual for patients who have a B12 deficiency to also have a folate deficiency. So we always want to measure B12 in patients who have folic acid deficiency anemia. Patients could have all the anemias, or they could have one or the other. When you're looking at your labs, when you're doing your differentials, you need to start breaking all of these apart to have your brain start honing in on, why is this hemoglobin low? Well, let's look at MCH, MCV. Is it microcytic? Is it normochromic? Is the red blood cell beefy and big? Is it little and gray? Now, we can do bone marrow biopsies. Looking at prevention, we want to avoid medications that interfere with folic acid absorption, like Phentoin, like sulfa drugs. Adequate dietary intake of folic acid, 400 mics, 600 mics if you're pregnant, 500 mics if you're lactating. What about non-pharmacological management? Increasing folic acid in your diet. Your recommended dietary allowance is about 400 mics of folate per day. What about dietary counseling for your patient? What are foods that are high in folic acid? Green leafy vegetables, meat from animal sources, fruits, nuts, liver, food containing yeasts. Pharmacological management. Vitamin B9, which is folic acid. If you are 11 years and older, we're going to give 1 milligram by mouth daily until the deficiency is corrected. For children ages 1 to 11 months, we're going to do 15 mics per kilo until the deficiency is corrected. For children's 1 year to 10 years, 1 milligram daily until the deficiency is corrected. Folic acid supplementation can go orally or parentally. You'll look in your drug book, there's 2, Folmor and Foltix. Both of those contain B12 along with folic acid of 2.5 milligrams. And neither one of those are FDA approved in the use of children. What about pregnancy and lactation considerations? Increased demand for folic acid, adequate folic acid intake before and during pregnancy for the prevention of what? You learned this back in nursing school, neural tube defects. We want to have and counsel our patients in the primary care setting that if they are of childbearing age, they should be on some sort of multivitamin or in a folate-rich environment. If they have low folic acid, we can have complications like spontaneous abortion, congenital abnormalities, abrupto placentae. And if possible, we're, consultation and referrals, we're going to go to a dietitian, gastroenterology, possibly a substance abuse counselor if the cause is from, chronic alcoholism or a possible, anorexia. Our follow-up is we're always going to reevaluate in 2 weeks to determine the response to therapy, and then we reevaluate every month until that patient is stable. Expected course, we're going to get a rapid increase in reticulocyte count with a peak in about 7 to 10 days after therapy started, and the hematocrit should rise within 1 week of initiation of therapy. What are possible complications of folic acid deficiency? Neural tube defects, failure to thrive, infertility. We can get premature graying of the hair. The hair can actually start to become curlier when a person has folic acid deficiency. Worsening heart disease. We could oversupplement with folate. We can get megablastic anemias. We can get leukopenias and thrombocytopenias. And in my last thing of talking about different hematological disorders for review today is our G6P6 deficiency, glucose 6-phosphate dehydrogenase deficiency. This is a normocytic anemia that is caused by the absence of the G6P6. congenital sex-linked red blood cell enzyme deficiency that leaves a patient susceptible to hemolysis after ingestion of substances with oxidant properties. And there's different classes. There's class 1 through 5, class 1 being the most severe, and class 4 and 5 having minimal to no clinical significance. This is an X-linked recessive disorder. Incidence rate, most common enzymatic disorder of the red blood cell, most prevalent in persons from Mediterranean and African descent, common in Saudi Arabians, Africans, and African Americans. Affects about 16% of African American males and 1 to 2% of females, and affects roughly 400 million people. What are our risk factors? Mediterranean, African descent, family history of G6P6 deficiency, drugs with a high redox potential, anti-malarials, chloroquine, your sulfides, your aspirins, nitrofurantoin, sulfa drugs like Bactrim. Fava beans, of all things, can be a risk factor. And in neonates, it's caused by decreased bilirubin elimination. So assessment findings. What's the degree of G6P6 will determine its actual clinical presentation. So symptoms develop about 24 to 48 hours after ingestion of the substance that has that oxidant property. So neonates, they'll present with this within about 24 hours of birth. They'll have pallor, tachycardia, shortness of breath, jaundice, dark urine, hematuria, splenomegaly, hemolytic anemias, and other chronic hemolytic anemias of our adult patients. Most patients with G6P6 will have no symptoms, but if they ingest a certain specific type of substance, they will develop acute hemolytic anemias. So differential diagnosis, alpha and beta thalassemia, sickle cell anemia, hemolytic anemia, sideroblastic anemia, anemia of chronic disease, which we already discussed, hypothyroidism, kernicterus, hemolytic disease of the newborn, lead toxicity. What are the diagnostic studies? We're going to do CBC, hemoglobin hematocrit. They'll probably be decreased during an acute episode. Reticulocyte count will be increased. Remember, those retics are immature. They're just getting sent out. We got a mean corpuscle volume is probably going to be normal. Your G6PD level is going to be decreased, but could be falsely elevated during an acute episode. So we're going to remeasure 1 to 2 weeks after that acute episode. We're going to look at RBC count. What is varied about the morphology? Is the morphology peculiar? Haptoglobin level is going to be decreased. That is indicated of severe intravascular hemolysis. Direct and indirect bilirubin will be increased because there is RBC destruction. Your LDH, lactate dehydrogenase, is going to be increased because of that RBC hemolysing. Looking at the peripheral smear, there's going to be Heinz bodies. There's going to be bite cells, there's going to be blister cells. This is all denatured hemoglobin. The urinalysis will show hematuria. There'll be, other signs in that peripheral smear. For prevention, we're going to screen people. We're going to look at risk factors. We're going to look at family history. Non-pharmacological management. Most people don't need treatment. They just need to avoid things that can trigger an episode of hemolysis. They may need packed red blood cells. Neonates might need an exchange transfusion. And if the person has hyperbilirubinemia, they're going to need phototherapy. Pharmacological management, usually not needed for this type of anemia. We're going to treat the anemia appropriately, recognizing that hemolysis will resolve in about 8 to 14 days. Folic acid, if there's chronic hemolysis, we're going to probably supplement with folic acid. Consultation referral, hematologist, and a geneticist. Our expected course of treatment is an excellent prognosis if diagnosed early, and the patient avoids the substances that trigger the hemolysis. After an acute episode, hemoglobin levels can return to normal in about 2 to 6 weeks. Possible complications: severe hemolytic anemia, kernicterus, kidney failure, or death. post-severe hemolytic event can lead to complete destruction of the kidneys. So that is it for this week's lecture on hematological anemias. Make sure you read in your book the different treatments for anemia, because that is part of your chapter quiz and will be on your midterm.